how they're going to be able, there we go. This is how they're going to be able to have the link in order to view the sync session afterwards. So this is a good transition with this whole thing with recording. So so there were some questions that were asked. You guys, please feel free to email me with any questions. That way I can triage those questions and try to get things done in a timely fashion. So regarding the post sync slides, I say they're post sync slides, but they're a PDF. So there's not going to be any like recording per se, or a PowerPoint. When you get those, when I put those in the post sync materials, that's really just a PDF. It's not like the concrete PowerPoint slides. So what I did when you go to your modules section, in Canvas. In that LMS, what I did was I created a different module and it has sync recordings. So every time we have a sync session, they should appear there, but you have to give me time to put them in because Teams has to get it recorded and comprised and transcribed, etc. Once that's done, I will share that link in there, and then you will have a recording of this entire service or session. Is that cool? Okay.
Because
All right. So what you have is in that particular section of Canvas, you have, I think I could get sync number 2. So sync session number 2 is already there for you. Now, I did get an email yesterday or on Tuesday in the evening. So with emails, you guys, if you don't get immediate response for me, just give me a little bit of grace because I usually get like 24 hours to respond, but I do try to respond as soon as I can. And if it's on the weekend, I probably will not respond until Monday, but I'll try to respond early in the morning. Um, so the question was regarding, let me find it. Um, Going over the PowerPoint topics and pointing out important information and points, things like quizzes and midterms and discussion board, etc. Just I know to help just make the studying a lot easier, right? So before your midterm, I think in week 4, I'm going to put out what I call an exam blueprint, or just a study guide. Now, within that study guide, I'm not going through that and giving you every single thing to study word for word, question for question, but I'm giving you the gist of what you need to focus on so that you're not trying to focus on every single thing. When I do the sync sessions are really a true supplement of all of those PowerPoints that are in your modules. How many of you guys have looked at those PowerPoints? Okay. And I know that there are a lot of them, but bear with me because as you matriculate through the course, you'll find that there might only be 1 or 2 topics. The topics are going to depend on how many pathologies we're going over. So if we're only going over 2 pathologies, then you're probably only going to have 2 PowerPoints. If we're only going over 1 pathology, I might take all of that information and I might break it down into 2 PowerPoints or keep it just one so that you don't seem as if you are, totally overwhelmed, with what's going on within all of them. But when you get these sync slides or when we do these sync sessions, these are pretty much the nuts and the bolts of what's going to actually be within your test, your midterms, your quizzes, etc. What you get in sync session is what I am actually highlighting for you, that this is going to appear probably on your midterm exam, on your final. As far as with the board exam, a lot of what I'm giving you during sync sessions is what I want you to focus on because these are the types of questions that you probably will get when you're taking your boards. So I'm hoping that I'm answering that question because I felt like, one person did ask, but I wanted to make sure I addressed the entire class because if one person had the question, then there might have been more people that had the same question. Yeah. Okay.
yeah,
Um, does anyone have any questions so far? No? Okay. All right. Then with that being said, I'll go ahead and get started. And we're going to talk about stroke pathology and epidemiology, okay? Do any of you know any stroke survivors? Yeah. Um, do they still have any residual effect from a stroke?
Yes.
Yeah. Is it something that's really obvious and apparent, or is it something where, they have all of their functional mobility, or maybe they have like some speech language issues that you see? Do you see any impairments or any type of issue with that person?
Their gait,
Yeah. What does their gait look like?
they have like a hemiplegic gait.
Do they have to walk with any type of assistive device?
A cane sometimes.
Yeah, okay, sometimes. Okay. All right. So usually when I start stroke, I like to, even though I did put it on your in your canvas, I really and truly like to start with this video of a TED Talk of a woman who experienced a stroke. And the nice thing about it is that, well, I guess I can't say anything is nice about having a stroke, but for her, the advantage was she is a neuroanatomist. And so, with her being a neuroanatomist, she was able to kind of pinpoint a lot of the things that happened to her. So, I want to share my screen with you for this. Can you see the PowerPoint? I mean, can you see the YouTube video?
Yes.
Yeah. Okay. I'm going to unmute it.
Who has been diagnosed with a brain disorder, schizophrenia. And as a sister, later as a scientist, I wanted to understand, why is it that I can take my dreams, I can connect them to my reality, and I can make my dreams come true? What is it about my brother's brain and his schizophrenia that he cannot connect his dreams to a common and shared reality, so they instead become delusion? So I dedicated my career to research into the severe mental illnesses. And I moved from my home state of Indiana to Boston, where I was working in the lab of Dr. Francine Bennis in the Harvard Department of Psychiatry. And in the lab, we were asking the question, what are the biological differences between the brains of individuals who would be diagnosed as normal control, as compared with the brains of individuals diagnosed with schizophrenia, schizoaffective, or bipolar disorder? So we were essentially mapping the microcircuitry of the brain, which cells are communicating with which cells, with which chemicals, and then in what quantities of those chemicals. So there was a lot of meaning in my life because I was performing this type of research during the day. But then in the evenings and on the weekends, I traveled as an advocate for NAMI, the National Alliance on Mental Illness. But on the morning of December 10, 1996, I woke up to discover that I had a brain disorder of my own. A blood vessel exploded in the left half of my brain. And in the course of 4 hours, I watched my brain completely deteriorate in its ability to process all information. On the morning of the hemorrhage, I could not walk, talk, read, write, or recall any of my life. I essentially became an infant in a woman's body. If you've ever seen a human brain, it's obvious that the two hemispheres are completely separate from one another. And I have brought for you a real human brain. Thank you. So this is a real human brain. This is the front of the brain, the back of the brain with the spinal cord hanging down. And this is how it would be positioned inside of my head. And when you look at the brain, it's obvious that the two cerebral cortices are completely separate from one another. For those of you who understand computers, our right hemisphere functions like a parallel processor, while our left hemisphere functions like a serial processor. The two hemispheres do communicate with one another through the corpus callosum, which is made up of some 300 million axonal fibers. But other than that, the two hemispheres are completely separate. Because they process information differently, each of our hemispheres think about different things, they care about different things, and dare I say, they have very different personalities. Excuse me. Thank you. It's been a joy. Our right human hemisphere is all about this present moment. It's all about right here, right now. Our right hemisphere, it thinks in pictures, and it learns kinesthetically through the movement of our bodies. Information in the form of energy streams in simultaneously through all of our sensory systems, and then it explodes into this enormous collage of what this present moment looks like, what this present moment smells like and tastes like, what it feels like, and what it sounds like. I am an energy being connected to the energy all around me through the consciousness of my right hemisphere. We are energy beings connected to one another through the consciousness of our right hemispheres as one human family. And right here, right now, we are brothers and sisters on this planet, here to make the world a better place. And in this moment, we are perfect, we are whole, and we are beautiful. My left hemisphere, our left hemisphere, is a very different place. Our left hemisphere thinks linearly and methodically. Our left hemisphere is all about the past, and it's all about the future. Our left hemisphere is designed to take that enormous collage of the present moment and start picking out details, and more details about those details. It then categorizes and organizes all that information, associates it with everything in the past we've ever learned, and projects into the future all of our possibilities. And our left hemisphere thinks in language. It's that ongoing brain chatter that connects me and my internal world to my external world. It's that little voice that says to me, hey, you got to remember to pick up bananas on your way home. I need them in the morning. It's that calculating intelligence that reminds me when I have to do my laundry. But perhaps most important, it's that little voice that says to me, I am. And as soon as my left hemisphere says to me, I am, I become separate. I become a single, solid individual, separate from the energy flow around me and separate from you. And this is the portion of my brain that I lost on the morning of my stroke. On the morning of the stroke, I woke up to a pounding pain behind my left eye. And it was the kind of pain, caustic pain, that you get when you bite into ice cream. And it just gripped me. And then it released me. And then it just gripped me. And then it released me. And it was very unusual for me to ever experience any kind of pain. So I thought, okay, I'll just start my normal routine. So I got up and I jumped onto my cardia glider, which is a full body, full exercise machine. And I'm jamming away on this thing. And I'm realizing that my hands look like primitive claws grasping onto the bar. And I thought, that's very peculiar. And I looked down at my body and I thought, whoa, I'm a weird looking thing. And it was as though my consciousness had shifted away from my normal perception of reality, where I'm the person on the machine having the experience, to some esoteric space where I'm witnessing myself having this experience. It was all very peculiar, and my headache was just getting worse. So I get off the machine, and I'm walking across my living room floor, and I realize that everything inside of my body has slowed way down. And every step is very rigid and very deliberate. There's no fluidity to my pace, and there's this constriction in my area of perception. So I'm just focused on internal systems. And I'm standing in my bathroom getting ready to step into the shower, and I could actually hear the dialogue inside of my body. I heard a little voice saying, okay, you muscles, you got to contract, and you muscles, you relax. And then I lost my balance, and I'm propped up against the wall. And I looked down at my arm and I realized that I can no longer define the boundaries of my body. I can't define where I begin and where I end because the atoms and the molecules of my arm blended with the atoms and molecules of the wall. And all I could detect was this energy. And I'm asking myself, what is wrong with me? What is going on? And in that moment, my brain chatter, my left hemisphere brain chatter, went totally silent. Just like someone took a remote control and pushed the mute button, total silence. And at first, I was shocked to find myself inside of a silent mind. But then I was immediately captivated by the magnificence of the energy around me. And because I could no longer identify the boundaries of my body, I felt enormous and expansive. I felt at one with all the energy that was, and it was beautiful there. And then all of a sudden, my left hemisphere comes back online and it says to me, hey, we got a problem. We got a problem. We got to get some help. And I'm going, oh, I got a problem. I got a problem. So it's like, okay, I got a problem. But then I immediately drifted right back out into the consciousness. And I affectionately refer to this space as La La Land. But it was beautiful there. Imagine what it would be like to be totally disconnected from your brain chatter that connects you to the external world. So here I am in this space, and my job and any stress related to my job, it was gone. And I felt lighter in my body. And imagine all of the relationships in the external world and any stressors related to any of those, they were gone. And I felt this sense of peacefulness. And imagine what it would feel like to lose 37 years of emotional baggage. Oh, I felt euphoria. Euphoria. It was beautiful there. And then again, my left hemisphere comes online and it says, hey, you've got to pay attention. We've got to get help. And I'm thinking, I got to get help. I got to focus. So I get out of the shower and I'm mechanically dressed and I'm walking around my apartment and I'm thinking, I got to get to work. I got to get to work. Can I drive? Can I drive? And in that moment, my right arm went totally paralyzed by my side. Then I realized, oh my gosh, I'm having a stroke. I'm having a stroke. And then the next thing my brain says to me is, wow, this is so cool. This is so cool. How many brain scientists have the opportunity to study their own brain from the inside out? And then it crosses my mind, but I'm a very busy woman. I don't have time for a stroke. It's like, okay, I can't stop the stroke from happening, so I'll do this for a week or two, and then I'll get back to my routine. Okay, so I got to call help. I got to call work. I couldn't remember the number at work. So I remembered in my office, I had a business card with my number on it. So I go into my business room, I pull out a 3-inch stack of business cards, and I'm looking at the card on top. And even though I could see clearly in my mind's eye what my business card looked like, I couldn't tell if this was my card or not because all I could see were pixels. And the pixels of the words blended with the pixels of the background and the pixels of the symbols, and I just couldn't tell. And then I would wait for what I call a wave of clarity. And in that moment, I would be able to reattach to normal reality. And I could tell, that's not the card, that's not the card, that's not the card. It took me 45 minutes to get 1 inch down inside of that stack of cards. In the meantime, for 45 minutes, the hemorrhage is getting bigger in my left hemisphere. I do not understand numbers. I do not understand a telephone, but it's the only plan I have. So I take the phone pad and I put it right here. I take the business card, I put it right here, and I'm matching the shape of the squiggles on the card to the shape of the squiggles on the phone pad. But then I would drift back out into La La Land and not remember if when I come back, if I'd already dialed those numbers. So I had to wield my paralyzed arm like a stump and cover the numbers as I went along and push them so that as I would come back to normal reality, I'd be able to tell, yes, I've already dialed that number. Eventually, the whole number gets dialed, and I'm listening to the phone, and my colleague picks up the phone, and he says to me, and I think to myself, oh my gosh, he sounds like a golden retriever. And so I say to him, clear in my mind, I say to him, this is Jill, I need help. And what comes out of my voice is, and I think, oh my gosh, I sound like a golden retriever. So I didn't know that I couldn't speak or understand language until I tried. So he recognizes that I need help, and he gets me help. And a little while later, I'm riding in an ambulance from one hospital across Boston to Mass General Hospital. And I curl up into a little fetal ball. And just like a balloon with the last bit of air just right out of the balloon, I just felt my energy lift and I felt my spirit surrender. And in that moment, I knew that I was no longer the choreographer of my life. And either the doctors rescue my body and give me a second chance at life, or this was perhaps my moment of transition. When I woke later that afternoon, I was shocked to discover that I was still alive. When I felt my spirit surrender, I said goodbye to my life, and my mind was now suspended between two very opposite planes of reality. Stimulation coming in through my sensory systems felt like pure pain. Light burned my brain like wildfire, and sounds were so loud and chaotic that I could not pick a voice out from the background noise, and I just wanted to escape. Because I could not identify the position of my body in space, I felt enormous and expansive, like a genie just liberated from her bottle. And my spirit soared free like a great whale gliding through a sea of silent euphoria. Nirvana. I found nirvana. And I remember thinking there's no way I would ever be able to squeeze the enormousness of myself back inside this tiny little body. But then I realized, but I'm still alive. I'm still alive, and I have found nirvana. And if I have found nirvana and I'm still alive, then everyone who is alive can find nirvana. And I pictured a world filled with beautiful, peaceful, compassionate, loving people who knew that they could come to this space at any time and that they could purposely choose to step to the right of their left hemispheres and find this peace. And then I realized what a tremendous gift this experience could be. What a stroke of insight this could be to how we live our lives. And it motivated me to recover. 2.5 weeks after the hemorrhage, the surgeons went in and they removed a blood clot the size of a golf ball that was pushing on my language centers. Here I am with my mama, who's a true angel in my life. It took me 8 years to completely recover. So, who are we? We are the life force power of the universe with manual dexterity and 2 cognitive minds. And we have the power to choose moment by moment who and how we want to be in the world. Right here, right now, I can step into the consciousness of my right hemisphere where I am the life force power of the universe. I am the life force power of the 50 trillion beautiful molecular geniuses that make up my form, at one with all that is. Or I can choose to step into the consciousness of my left hemisphere, where I become a single individual, a solid, separate from the flow, separate from you. I am Dr. Jill Bolte Taylor, intellectual, neuroanatomist. These are the we inside of me. Which would you choose? Which do you choose? And when?
All right. Thanks for your patience with that, you guys. I just really love to show this particular YouTube video before I get started with stroke and stroke pathology and all of the stroke syndromes, just because it just helps to put things into perspective. And the rarity of someone going through intracerebral hemorrhage and being able to actually have a full account of what happened is quite rare. So here we go. All right. So when we are talking about a stroke is defined as a sudden loss of neurological function. It's caused by an interruption of blood flow to the brain. When you are having a stroke, it is categorized as being either an ischemic stroke or a hemorrhagic stroke. If it's an ischemic stroke is basically a thrombus or a clot. A thrombus is a clot, they're the same thing. And it's going to block and impede blood flow or restrict blood flow to certain areas or within areas of the brain. With a hemorrhagic stroke, that's going to be where blood vessels are going to burst, and it's going to cause a leakage of blood in or around brain tissue. So please be sure to understand and know the difference between the two types of strokes that someone can have. One, an ischemic stroke where blood flow is blocked. Two, a hemorrhagic stroke where there's bleeding that's going to occur within the brain. As far as the epidemiology, in previous years, stroke has had um, a higher numerical rating or counting. A couple years ago, it was fourth. However, due to COVID, stroke is now the fifth leading cause of death and the most common cause of disability. Um, epidemiology wise, compared with white people, Black people have twice the risk of having a first ever stroke. And then the rates are still even higher in Mexican Americans, Native Americans, and Alaskan Natives. And your predisposition to having a stroke increases dramatically with age, and that chance or potential doubles after the age of 65. So, in your module, there was a video that talked about brain circulation, the circulation and blood flow. And so, what you have to consider with strokes is the circle of Willis and those major branches that come off of the common carotid artery and that come off of the vertebral basilar artery. So you have the major contributory factor for someone having the stroke is going to be atherosclerosis. That's going to lead to narrowing of the arteries. And the most common location or the site of those to happen is along the common carotid artery when it bifurcates or splits into the middle cerebral artery and the anterior cerebral artery. So now let's focus our lens on the ischemic stroke and talk just a little bit more about that. So remember, as aforementioned, ischemic strokes are a result of a thrombus or an embolus. Now, an embolus is, if you've ever heard of a PE or a pulmonary embolism, an embolus is basically when you have a clot that loosens up within the vessel and it floats freely within the vascular system until it either hits the lungs or it hits the heart. At that moment when it breaks off, it's called an embolus or an embolism. So a thrombus, so the ischemic strokes are a result of a thrombus, a floating thrombus or an embolus, or conditions in which there is a low systemic perfusion pressure. And that just means that the brain is not getting an adequate amount of oxygen delivery. So I have those listed here for you to go through. You'll be tested over those as well. Switching over to hemorrhagic strokes. Remember, this is when you have bleeding either in the brain or you have bleeding on the brain. So you have two different types that are probably the most problematic. The first one is an intracerebral hemorrhage, and normally that's going to be a rupture of an aneurysm within the brain, causing bleeding that's going to press against or give pressure against cerebral tissue. And then you can have what's called a subarachnoid hemorrhage. Now, with a subarachnoid hemorrhage, it's going to take place within the subarachnoid space. So that's the space that's between the pia mater and the arachnoid mater. And if you're not understanding those terms, make sure that you go back and you look at the module 2 or the module 3 information that regarding the meninges and the meningeal layers. But I'll be happy to answer any questions if you have them in regard to the meninges. So just stop me and let me know, or I'll just kind of keep going. Okay. The difference with hemorrhagic strokes is oftentimes when it's in that subarachnoid space, you'll have a person, as far as the clinical signs and symptoms, there can be a loss of consciousness, but they will complain that it is the worst headache that they have ever had in their life. If they suffer from migraines as well, they'll say that the headache is worse than any type of migraine they've ever had. And that's called a thunderclap headache. So oftentimes it's really taken serious when someone enters into the ED or the emergency room or emergency department and they complain that they just have this horrific headache. And it's not a migraine quality, but it's a lot worse than that. They will usually, or they're supposed to triage that patient and get that patient a CT scan to see if they are suffering from effects of a stroke. Now, with those hemorrhagic strokes, oftentimes a person is not even aware that they have anything like an aneurysm that could potentially burst. Sometimes that can be congenital, in which a person has what's called AV or atriovenous malformation. And you might see on the board exams where they say AVM. It's pretty much the same thing. And it's characterized as just this awful tangle of veins and arteries that's going to eventually rupture. It just depends. Normally, with it being congenital, a lot of individuals really don't know they have it unless something traumatic happens where they have to get some type of MRI or a CT scan to the brain. And so, personally, I knew a woman from church. Her daughter was going to college out in California, and she had a congenital AVM malformation, and they were unaware of it. However, she went to the emergency room and told them that she was having this horrific headache. And instead of triaging her, they sent her home. But then maybe a couple hours later, she went back. And I think they just thought she might have been drug seeking. So they sent her home again. So that's twice. So then the third time, her roommate bought her back and had called her parents and had her parents on the phone. And they're like, you guys have to do something about this because this is the third time she's been back to the ED. And so what they found out is that she had an AVM and the AVM had ruptured. So she had to have immediate surgery in order to correct that issue. So now let's kind of transition into what are some of the risk factors of someone who has suffered from a stroke or who's predisposed to having a stroke. So when we talk about risk factors, you can have risk factors that are modifiable, and then you can have risk factors that are non-modifiable. And with those risk factors, make sure that you understand the ones that are modifiable versus the ones that are non-modifiable. So those risk factors can include hypertension, heart disease, um, cardiac dysrhythmia or disorders of heart rhythm, and diabetes. And then in medicine, we go further and we block those and we put them to the side as far as are they modifiable or non-modifiable. So the modifiable risk factors are the ones that we can actually get patient education on, right? So that's smoking, that's living a sedentary life leading into a lack of exercise and potential obesity, and then what that person is eating. So their diet, and we're trying to make sure they have a pretty healthy diet to stave off the signs of a stroke. or the predisposition to them having a stroke. And then the non-modifiable risk factors are family history, the person's age, their gender, and their race. So here's another thing I want you to watch, and I want you to observe this video, and I want you to pick out what the person's warning signs, what's the warning signs of a stroke? And I'm just trying to figure out if you guys are aware of it.
Now he's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom.
Probably nothing.
Dad.
Oh, my apologies. Start that again.
Okay. You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911.
I said,
Honey?
Oh, Dad.
Tim,
I need an ambulance. It's 7th floor.
Tim, Tim, look at me, Gracie. Tell them to hurry. Tim, look at me. Look at me, Tim.
Mom, what do I
Dad,
tell
I
him?
don't know. I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going
Dad?
on, baby? Yes, but he. It's cold. Are you cold, honey? Are you cold?
Okay, I'm going to pause that for just a second. Tell me, what are some of the signs that you saw?
Slurred words.
Okay, slurring of the words. What else?
The drooping on one side of the face.
Drooping on one side of the face. What else?
He could only raise one of his arms.
Absolutely, he could only raise one of his arms. And give me one more.
Loss of consciousness.
Was it a loss? Did he lose consciousness, or what did he do to make you think he lost consciousness?
Stop responding.
Stop responding. I'm sorry, I didn't hear that last statement.
He stopped responding and closed his eyes.
Okay, he stopped responding and he closed his eyes. And when he did that, what else did he do? He kind of lost his balance, right? He kind of sloped over to one side. Okay, so as clinicians, we always have to know our warning signs. Okay, I'll play the rest of it now.
Gracie? I think Gracie's gonna come, sweetheart. We're just gonna go. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay. Huh? Right here. I'm right here. Gracie, meet us there. Right here. I'm right here. Okay. Stay right here. You stay and breathe. Tim? Tim?
Dad?
Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
Okay. So with this, gang, make sure that as far as when you get out in the clinic and you start practicing, or even just personally in your personal life, make sure that you can recognize those early warning signs. So some things that this gentleman went through as far as those early signs are, you get the sudden numbness or weakness of one hemibody or one side of the body. So that's weakness through the arm, the trunk, the legs. There's a sudden confusion and trouble speaking or understanding, or even both. Usually that person will have blurry vision. So there's going to be trouble seeing in one eye or both eyes. They're going to have an issue with loss of balance. They might have an issue with coordination, trouble walking, or dizziness, but definitely in there, that loss of balance. They will complain of having a very sudden and severe headache. And it's idiopathic. And idiopathic means that there's no known cause. It's just all of a sudden it happens. And then once again, there's that impaired balance. So the American Heart Association has come up with this acronym of Be Fast. And Be Fast, it gives you those signs and symptoms. It's just a way to remember them. So they're going to have an issue with their balance. They might have blurred vision. F for their face, one side of the face might have that facial drooping. They might have arm and leg weakness, and then their speech might be impaired. And then T is the time. So you have that time for when you call that ambulance. And so the saying of time is brain is very important with both an ischemic stroke and with a hemorrhagic stroke. Because what happens is the stroke team basically comes in and they're in the ED. And when they're there, they're going to take that patient through a brief series of neurologic tests. And then that patient's going to receive a CT scan to see if that stroke is either hemorrhagic or if it's thrombic. If it's an ischemic or that thrombic stroke, then what they'll do is they will administer what we call TPA to this patient. And normally, if this medication is given to this patient within 3 hours of of the onset of the stroke, then that's been known to be very effective per evidence in a better stroke recovery. And that TPA stands for tissue plasminogen activate. And so what it does is it breaks down the blood clots because it's administered intravenously. Now, there are times when that thrombus might be really, really large. And so, what they'll do in conjunction with that TPA is they can go in through the femoral artery and they can perform a thrombectomy. So, they send like a little line with a little pincher grasper on the end of it, and it can go all the way through the heart and it can go up into the brain and it can just pinch and remove or pull that clot through. Okay. So, as far as the damage of what's done, okay. So, when someone has a stroke, I tried to keep this, it's called an ischemic cascade, and I tried to keep it kind of easy and under 6 bullet points. I just gave you 3 to memorize, okay? So, with the pathophys of what happens to the brain or that central nervous system or brain tissue is this. When someone has a stroke, there's going to be some type of neuronal cessation or cell death or neuronal death. So within minutes, you have neurons that are going to die. You have neuronal activity that's going to stop or cease, and the infarct expands. So the clotting expands, or the lack of blood supply is going to get worse, and it's going to cause an ischemic cascade. So with these ischemic strokes, they're going to produce a lot of swelling within the brain from onset to maybe 3 or 4 days after. And then it's going to gradually subside within 2 to 3 weeks. Okay. But if it doesn't, what happens is you can have an increased elevation of intracranial pressure. That's ICP. And so usually that increased pressure and the death of a lot of those neuronal cells are characteristic of very large infarcts or large strokes. So when I say an infarct, I mean the stroke. And that's usually going to be the middle cerebral artery and the internal carotid artery that are pretty much predisposed to those. So another way that we manage strokes is this. You have a TIA, which is a transient ischemic attack, is what we'll call that. And that's normally when you have stroke symptoms that last for maybe a few minutes or several hours, but the residual effect is gone within 24 hours. And usually, if someone has a TIA, they call it's like a temporary interruption of blood supply. And if you have one, then now you're going to have more of a predisposition and maybe some months later or a year later to having a full-fledged stroke. You can have what's called a major stroke. And a major stroke usually has a lot of severe impairment, but that person is stable. So you can get them stable, but they might have an issue with their speech. and communication. They might have an issue with their perception, and they're really severe. They might have issue with hemiparesis and their gait, and it's really, really severe. With a deteriorating stroke means that the person is just continuously getting worse after they have been admitted to the hospital and they have a pretty bad mortality rate. And a young stroke is just what it says. It's a stroke that affects people younger than 45 years of age. So that's when you can have, an infant that because of some type of congenital issue, they might be predisposed to stroke. You have younger people who have sickle cell anemia where their blood vessels are going to sickle and they don't have enough oxygenation within their vasculature, and those individuals are predisposed to having strokes as well. Any questions so far before I switch topics, you guys? You hanging in there with everything? Okay. All right. So I'm going to segue into topic 2, which are your stroke syndromes. This is a really important topic. You're going to be tested pretty much on all of those syndromes. So make sure that you go through them. The biggest thing or the study tip that I would have regarding the stroke syndromes is they are all unique. They have unique characteristics about what they're going to affect primarily. Okay. So I'm going to make sure that I kind of highlight those as we go through. So to understand the strokes, especially the hemorrhagic ones, are you guys hot? Sorry.
Sorry.
Okay. So as I aforementioned, knowing those meninges, especially for the hemorrhagic strokes and actually where the blood is pocketed within like called a hematoma, then you have to know the layers, the meningeal layers. So I'm going to briefly go over those. I'm praying that you guys discussed meninges in anatomy. Did you guys discuss meninges in anatomy?
Yes.
Okay, perfect. So I'm hoping that this is a review. If you didn't understand it then, I hope this gives you a little bit more clarity on an understanding on meninges. So I'm going to keep it simple. With meninges, you have the meninges, they're in the brain and then they're in the spinal cord. They're oriented differently when they're in the cord. And I'm not concerned with you guys at this point understanding the meninges and how they're organized in the cord. I'm more or less, I want you to understand how they're organized in the brain. So that's on the upcoming slide. So you have 3 layers of meninges that cover the brain and they cover the spinal cord. From superficial to deep, you have the dura mater first. The second layer is the arachnoid mater. And then the third layer is the pia mater. So when you think about the layers, dura really means like durable, right? And that's the layer that's directly beneath the skull. Okay. And so they call it their toughest outermost layer, and it serves as a nice protective layer for brain tissue. And then you have your arachnoid mater that's characterized as having just nice delicate tissue within it. And it has what we call trabeculae and granulations. And those are just they become a part of the waste system in order to remove waste from blood that's within the brain. That's just an overview of its function, but I'm not having you dig into the weeds on that. And then you have the pia mater that's pretty much directly connected to your brain tissue. So within the brain, this is how, from superficial to deep, this is how the meninges are organized. You're going to have the bone or your skull, okay? And then you're going to have in that like sky blue or ice blue color, you have your dura mater. And then you have your arachnoid mater, which gives room for or gives account for all of these little striations here. Those are called trabeculae. And then you also see beneath or subdurally or subarachnoid, you see all of those little veins and blood vessels that are running through that layer. And then you have that nice, delicate pia mater that's directly connected to your brain tissue. Now, within the brain and within the spinal cord, we have these hypothetical spaces. They're hypothetical spaces until you have trauma. When you have trauma that occurs, that potential hypothetical space becomes a real space. Okay. So, what you'll notice here between the bone or the skull and the dura mater, there's this little line here. Between that is the epidural space. And then you have beneath the dura, but above the arachnoid mater, another potential space, and that's called a subdural space. Now, one nice, very true bit of trivia that you should remember is that the only true spacing that we have within the meningeal layers are going to be between the arachnoid mater and the pia mater, and that's that subarachnoid space. So let's put that on the screen so that you'll understand it a little bit more. So here is the epidural space. And with that epidural space, it is a hypothetical space that doesn't come into true existence until there's a bleeding that occurs there or some type of trauma. So it's only present due to pathology when the dura mater separates from the skull and you have bleeding that will occur there. And that's how you get the name epidural hematoma, an epidural hematoma. Epi meaning above, okay, above the dura, but it's going to be below the skull. You guys get that? Understand that? Okay.
Yes.
All right. So then in the cord, we also have that same space. We have that epidural space. And I just put this here. This is just FYI. When you have someone that's going into labor and delivery, that's where they're going to issue that patient's injection for pain relief. When they get the epidural, they're getting it in that epidural spacing. So just a bit of trivia. So the next handful of slides just talk about and characterize those meninges for you. So you have your dura mater that's characterized as being very thick, it's tough, it's durable, it's composed of a lot of collagenous connective tissue. It's two layered. So you have the part of the layer that's against the skull, and then the other part of the layer that's going to be against the arachnoid mater. I'm not digging into the weeds on that. What I want you to know is that it's the outermost meningeal layer and how it's characterized as being like just a very tough protective meningeal layer. And then we're moving from superficial to deep. Beneath the dura mater is that next hypothetical space, and it's below the dura mater. So it's the subdural space. So it's going to be the potential space between the arachnoid mater and the dura mater. Okay. And then the next meningeal layer is your arachnoid mater. It's your middle layer. It has those spider-like processes called trabeculae or arachnoid trabeculae. It contains a lot of granulations and villi that are going to reabsorb cerebral spinal fluid. So, and just matter that should not be in the brain if it was allowed to cross over from the blood-brain barrier. And so all I want you to know is just superficially that it's the middle meningeal layer and what's inside of it, okay? What the arachnoid mater is composed of. It's going to sit below or inferior to the dura mater and above or superior to the subarachnoid space and pia mater, respectively. And then we have that very important, remember, this is the true space, the one true space is called the subarachnoid space. And this space is important because it contains cerebral spinal fluid and it contains blood vessels. It's the space that's going to be inferior or below the arachnoid mater, but above the pia mater. And then lastly, you have your pia mater, which is that innermost meningeal layer. It's characterized as being very thin, very delicate, and very translucent, and it's attached to the outermost layer of the brain. So if you ever in your life have the opportunity to participate in a brain dissection, you have to take your little tweezers and you can get it out of the sulci like really, really easy, but you're able to actually pick away some of that PTA matter. It's just really interesting to see that you can pick it away though, but it's very, very thin and it's just as translucent as it's described in your textbooks. So quick little quizzing here, okay? What space are you in? So if it's between the skull and the dura mater, what space is that between the skull and the dura mater? Not meninge, but space.
Subdural.
Subdural would be below. What's the word for above? Epi. So it'd be the epidural space. Woo woo. Hold on, let me go back. So there's your epidural space. Okay. Let's talk about between the dura mater and the pia mater. So now we're talking about below the dura mater. So what would that one be?
Subdural.
That's going to be your subdural space. Good job. And now let's go lower, okay? So now let's talk about what's between the arachnoid mater and the pia mater.
Subarachnoid.
The subarachnoid space. And what's the good trivia that you need to remember about the subarachnoid space? It's the one true space within the brain that's going to have all of the blood vessels, the veins, and the cerebral spinal fluid. If you have any type of clot happen in this area or hemorrhage happen within this area, this person is in deep trouble. This leads to backup of cerebral spinal fluid. It causes increased intracranial pressure. It might cause increased swelling of the ventricles, where that person might have to have a shunt and a backup of their cerebral spinal fluid. So, this is a very dangerous area to have bleeding or to have a clot. And like I said, that person complains of having that thunderclap headache, the worst headache that they've ever had in their life. Okay, so here's a potential question on what could show up on your board exam or what could show up on a final or a midterm from me. The dura mater is best described as what? What's your answer?
C.
C is the correct answer. Perfect. It's the outermost layer, tough and durable. It's double membrane and it adheres to the inner surface of the skull. Quick, easy, to the point, right? So this slide, I just put this in there as a recap of the orientation of the meninges and how they're arranged, just from superficial to deep. I'm not going to stay on this slide for too long because I know that I've already talked about it. But as far as how you would study, just understand superficial to deep as far as the layering of the meninges and the spaces between them. Okay, I think that this is almost 9:30. I think this is a good time maybe to take our break before I start in on brain vasculature because I don't want to stop in the middle of it. So if you guys don't have any questions, go ahead and take your 15 um, and then come back to me.
All right.
All righty.
You possibly have two band-aids, so I could.
Huh?
You have two band-aids that I could borrow.
Get a little container of them for you guys.
Well,
I'm gonna need another one later too.
Where I write, it's like getting raw because I've been writing a lot.
I don't personally have any, but I can find some for you. Anybody else need any while I'm looking?
Am I able to get back in here?
No, you are not. I will have to let you in and out. So does everybody want to go out there that way?
Yeah.
Let's do it now, and then I can go look. You can go ahead and walk right here. We'll have to come get you. Okay. Oh, thank you. You're welcome. You want a little one like this?
No.
I grabbed this by mistake. Uh-huh. Okay. Well, those are those. Those are those for you. Anything else I can get ya? Want some ointment?
$1,000,000.
Well, you know what? If I had that, I wouldn't be here. Right?
Somebody in the comments.
Well, enough now.
Well, pretty much. I mean, he had a firearm. Yeah, he was showing it off. Like I had some hot flashes going on.
You're a little young for that, aren't you?
But Hannah's younger than I am.
Oh, it's dictating everything we're saying.
You can turn that off.
And then it'll probably make the screen bigger.
You want some ointment?
What?
I just read it on the screen.
She asked me if I want ointment for my Band-Aid.
Yep, did you see I gave you a Band-Aid?
Mm-hmm. Thank you.
Is that bothering you?
Yes. Wait, you're gonna take it off for the whole thing?
The transcript?
Yeah.
Recording.
We can hear what she says. Plus, when it goes up on there, the words mess up anyway, and it says like random stuff up there.
It's like Siri.
I was reading.
I can turn it back on if you want.
I'm trying to take notes, so it's fine.
You want it?
He just literally asked, "You want in?" Wonder what did you do? I'm so tired. Look at this. Yeah, I've been waking. I've been going to bed at 11 and waking up at 5 just to do work. Mostly.
Waking up at 5 just to do work.
Well, I don't do
You're
that.
getting it done.
Recently, I've been going to bed late, but I need to be on a schedule. I was falling asleep during the interview last night.
Those have lines.
Yeah. It just like smacked me in the face. I didn't think it was that strong. But I was trying to be sure.
The brand is CSA.
Were they in like a black bag?
It's like a black bag with like color on it.
Right. I think it was like any. But
Where'd
my
you go,
Walmart?
Walmart?
My Walmart might not have been carrying them.
Sometimes those Walmart do that too.
Shores.
The Kia.
Mm-hmm.
have it.
I didn't realize there's still arresting people.
Yeah.
Who's Becky? Oh. Wait, is she drunk?
Oh,
That's why she said.
oh.
Okay, gang. How y'all doing? Y'all ready to start back up again?
We're ready.
Yeah. Okay. How's it going? I figured for a little bit I'm just going to be the stage on the stage just to make sure that you guys are understanding a lot of this material. Do you like this lecture format better?
I think so. I think
I like when you ask the questions in the middle of them.
Okay. All right. Okay, let's go ahead and get started. We are going to now kind of segue into those stroke syndromes. So we're going to talk about the vasculature first. And then after I talk about the vasculature, I'm going to explain what happens when this particular artery has a cerebrovascular accident or it bursts and there's a hemorrhage, etc. So on this slide, what you see are the components of the circle of Willis. Get my little laser ready. So this is the actual circle of Willis right here. The circle of Willis is pretty much comprised of the middle cerebral artery. It's larger here. Middle cerebral artery, and then you have the connector to the anterior cerebral artery. The connector is the anterior communicating artery. You have two of them. You're going to have one on each side. You have two MCAs or middle cerebral arteries, and you have two ACAs or anterior cerebral arteries. The posterior connector for the circle of Willis is going to be the posterior communicating artery. That's here. And then right here, you have your PCA or your posterior cerebral artery. So in the big scheme of things, when you look at it, that's what makes that anastomotic circle. Now that circle of Willis, and I think I talk about it on another slide, but I like this picture, so we'll talk about it here and then we'll review when it gets to the other one. The major function of the circle of Willis is it is a collateral system that is set up within the brain just in case there's a clot. So if you have, let's say you have a clot right in here, and let's say that now you don't have vasculature that's getting or blood that's getting to the posterior cerebral artery and all of the neuroanatomic regions that it supplies. Let's say you're not able to get blood up through this part of the posterior communicating artery, thus you're not getting as much blood flow even through the MCA. So what happens is you have a collateral system set up where instead of blood flow going this way because it's blocked, it has another way around to get to that area. Maybe it can't get there directly, but you will have that contralateral system or that collateral system set up where, well, if it's not coming through this way because there's a blockage here, I can get it through an alternative route, which is the other way around. Do you guys understand that? That is something that you guys will probably be asked on your board exams as well. Okay, so now with that being said, you have two major contributors to the vasculature of the brain. You have one that's going to come through the posterior aspect of the brain, the posterior inferior aspect of the brain, and you have the other one that's going to come through the anterior aspect of the brain. So you have the vertebral artery that enters posteriorly, and it's going to come through here. So let me come here. You have your two vertebral arteries here that are going to anastomose or come together, and they're going to form the basilar artery. And from the basilar artery, you're going to get small branches off of what we can call it the vertebral basilar artery. Sometimes it's used interchangeably as far as its title. And you're going to get these little striate arteries, which are called pontine arteries. And these arteries are going to supply the pons. You can also get your first line of attack or vasculature for the cerebellum by way of what you call the anterior inferior cerebellar artery right here. Okay. And then from there, you can come up and you also have your superior one here. Okay. Just know the difference between the superior cerebellar artery and the posterior cerebral artery. The posterior cerebral artery has the direct connection to the posterior aspect of the circle of Willis, okay? This is just from a 1,000-foot lens of what goes on with this vasculature. So let's start more anterior or in the front part of the brain. You have your ACA or your anterior cerebral artery. That's this artery right here, okay? You have one for the left and you have one for the right. Now, the ACA is going to supply the medial aspect or surface of the frontal lobes and the parietal lobes. So I have that marked for you in green, okay? So that's this entire green component here. You have the frontal lobe, you have the parietal lobe, and this is the medial aspect of the brain, okay? That inside component of the hemispheres. And as you can see, that vasculature is it's really expanded, because when you get to the lateral aspect, you only see where it's supplying like that uppermost superior aspect of the brain on the lateral end or the lateral aspect. But as you can see medially, you can see the expanse of that vasculature and what it supplies. Like it supplies the anterior superior component of the corpus callosum. It's also going to apply the anterior aspect of what we call the internal capsule, where a lot of those pathways go, those afferent, efferent, motor, and sensory pathways between the basal ganglia. It also is going to supply the anterior aspect of the basal ganglia as well. What I want you guys to know or understand is what it's supplying as far as that medial aspect of the brain and that very superior or topmost or upper aspect of the brain along the frontal and the parietal lobe. And then here in this particular image, it shows you, so you can see now where that ACA branches off of the internal carotid artery or the ICA. See that there? And then it goes upwards along that medial aspect of the brain. So that just gives you a nice picture of this expanse here when it enters into the brain. Okay. So this is what happens when there is an infarct or some type of trauma that occurs and it's within the ACA, and then it's going to affect what it supplies. So what you're going to find with that being in the frontal lobe, it's probably going to decrease vasculature along the primary motor cortex, right? It's probably going to inhibit Well, it does. It's some communication between the left and the right hemispheres because of the corpus callosum. We know that those fibers that transfer between the hemispheres, that's how they communicate the left from the right. And so when you went over in module 1, those neuroanatomical structures, remember that function of the corpus callosum is that communication. So these are some of the things that you're going to see. This is what happens. This is the syndrome, okay? You're going to have contralateral hemiparesis. It's going to affect the lower extremities more so than the upper extremities. Now, that's not to say that the upper extremities won't have involvement, but you're primarily going to see impairment in the lower extremities. You're going to have also a contralateral sensory loss. It's going to be more prominent in the lower extremities than the upper extremities. You're going to have urinary incontinence with this patient. And now we get into those motor issues, difficulty with imitation, initiation, and bimanual tasks with the hands. So that's getting into that supplemental motor association area. That's getting into that primary motor cortex. I am so sorry if you guys can hear my dog growling. She's fighting with my other dog, so my apologies. And she gets louder because she's a Pomeranian. Okay. You'll have gait apraxia because of the effect more so on the lower extremities. There's going to be a slowness or a delay or a lack of spontaneous movement. And that's because of that little bit of blood supply to the basal ganglia for that initiation of motion, right? And if you have basal ganglia issue, you can also have bradykinesia, which is slowness in movement. There's going to be issue with a contralateral grab reflex. So some primitive reflexes are going to come back into play potentially. Doesn't happen with everyone. There's going to be mild or asymptomatic a lot of these issues will be asymptomatic if that collateral vasculature system is working. So if the circle of Willis if the circle of Willis is competent, then oftentimes they're still getting blood supply, but it's just going around the corner to get it. The person also will have apathy or a lack of spontaneity. And oftentimes, that apathy and lack of spontaneity is going to depend on if it's the left side of the brain or the right side of the brain, or I should say, the left ACA or the right ACA that's affected. So, this picture or this image is a nice way to remember what's going to be affected. So I remember earlier I asked you guys maybe during module 1 sync session, did you know what the homunculus was? So this image here shows you a homunculus, and this is what I want you to pay attention to. This is going to occur on both sides. You have a red side over here. So you have a motor on both sides and you have a sensory on both sides, okay? But when they make this picture, they show it with just a sensory on one side and the motor on the other. Now, I want you to pay attention to are the body parts. And here's where you can see where it has a blue and a red on one side and a blue and a red on the other. If you look here, this is where the ACA is going to supply blood. Remember, it's going to be more along the medial aspect in between the hemispheres, frontal and parietal lobe. So look at here where you see this little foot, you see a knee, you see a hind part right here, and then the trunk along the superior aspect. And then you see in the genitals here, where they show it over here on sensory. So if someone has a lot of urogenital or that incontinence and lower extremity affect, both motor and sensory, that's going to be because of a lesion to the ACA. So really the homunculus is like a body map, okay, showing you what extremities are going to be more impacted or impaired. Now, if we move out here, we're not on the slide yet, but I'm going to talk about it because we're at the homunculus. If you move out along the lateral aspect of the brain, this is all supplied by the middle cerebral artery. So as you can see, if there's damage to the middle cerebral artery, most of the impairment or the effect is going to primarily be through the upper extremity, all the way from shoulder to hand, and in the face. And that's going to be for both motor and it's going to be for sensory. If you go to this middle picture here, this is also somatotopically divided for you. So what you see, just like the homunculus here, it just doesn't have the pictures, but it has the wording. So it has this being your central sulcus, this being the primary motor cortex for motor function, this being the sensory or the postcentral gyrus for sensory, or that primary somatosensory region. So as you can see, they're pointing right towards the middle part here. There's your leg and your foot. As far as the homunculus, it corresponds to here. And then along the lateral aspect, you have that hand, arm, face, and tongue. And that's all middle cerebral artery here. Is that understandable, gang? So you might have questions, and if they're MPTE formatted, then they're going to be questions saying you have a patient that presents with right hemiparesis. However, patient appears to have more of a severe effect along the lower extremities and has urogenital incontinence. Which blood vessel is most likely impacted or affected? And then they give you PCA for posterior cerebral artery. They might give you maybe ICA, anterior inferior cerebellar artery. They'll give you the MCA, middle cerebral artery, and they'll give you ACA, anterior cerebral artery. And then you have to pick. So your triggers are the location and the extremity that they give you. Is that understandable on how those questions could be configured for you? And then once again, I like this picture because it just shows all the vascular. So the green is going to be your ACA or anterior cerebral artery. All in blue here, that's going to be the middle cerebral artery. And in yellow, we haven't gotten there yet, but that is all posterior cerebral artery. So those three main arteries are the arteries that I'm going to expect you guys to understand and know what their syndromes are and what they supply. Okay, so segueing into the middle cerebral artery. Middle cerebral artery is a little bit more complicated than I would say the ACA is, because it has a lot of depth that you really can't see because we're only showing you in a lot of textbooks from the lateral aspect. But that doesn't mean that it doesn't hit some of that interior component. It's just more of the subcortical structures within the brain that it will hit or target. So if you see here along the lateral aspect of the brain, you see the divisions. You have this upper division or superior division and lower division. But if you see here, you can see where it comes in as the internal carotid artery. And then that internal carotid artery branches into your into your MCA. So here that is for you here. And then it has a superior branch and it has an inferior branch or division, depending on which way you want to say it. It's all the same thing. Internally, what you see with that internal branch is you see these small little branches or arteries. These are called lenticulostriate arteries. And lenticulostriate arteries are basically just small branches of the MCA. And this is what's going to supply those nice little internal subcortical structures within your brain. So if you look, I know that you guys can't tell yet, but what you have here is your internal capsule. That's that white pathway here. You also have your basal ganglia that surrounds your internal capsule. So right here, you have your caudate from this view, and then you have your globus pallidus and your putamen from this view. But look at, with that internal capsule, how many of your pathways can have effect or be affected if there is an infarct or a stroke in this area. Remember, there's a lot of motor efferent pathways that run through the internal capsule, and there's also a lot of sensory pathways. So sometimes you can have a pure motor effect where it's only affecting volitional motion and sensory would be intact. And in comparison or contrast, you can have where there's sensory that's affected, and the patient still has all of their motor function. So it just depends on where the infarct or the stroke is occurring. And then when the MCA travels along that outer lateral aspect of the brain that we can all see from the textbooks, then you get where it's supplying that lateral upper component of the brain, and then probably I would say the superior 1/3 of the temporal lobe. So from this view here, you can see your internal carotid artery here, or your ICA. And then as it comes in, it's going to bifurcate or blanch into your ACA, and then here is your MCA. So I'll just kind of keep going over those, because if you've never really studied these views, it's hard to orient yourself. So I'm more than happy to continue to do that. So here for you in black and white is what it supplies, okay? So that MCA is going to supply the lateral frontal lobe. So it's going to get a supply to Broca's area. It should say frontal and parietal. Oh, it says it later. So it's going to get that Broca's area right in here. And then it's going to also feed the lateral parietal lobe. So it's going to get Wernicke's area on the left side if something happens. It's going to supply the basal ganglia. It's going to supply the insula, the posterior portion of the internal capsule, and then optic radiations. And then you have those branches, which are those lenticular striate arteries. So in the big scheme of things, what do I need you to know? I need you to know if there is an issue with the MCA, especially the MCA on the left side of the brain, that person is probably going to have some communication issues. So if you remember our neuroanatomist, remember she said she couldn't speak. All of her communication centers were awry. So if that were the case, I would say that that hemorrhage occurred somewhere along this aspect of her brain. So with Broca's being in the front, that's your motor speech production region. You have Wernicke's back here in the temporal lobe, here in that top 1/3, and that's going to be where someone has an issue with language comprehension. Okay. So those two areas for her were definitely affected, but your communications will definitely be affected for left-sided MCA issues. I just want you guys to make sure that you understand that. So when we get to the syndrome, this is what you see. All the answers are right here for you. Occlusion of the proximal MCA is going to lead to some extensive neurologic damage. If you're talking about, or we're thinking about the homunculus, remember that the lateral aspect of the homunculus here is mostly going to be a lot of face, hand, and arm. So with those cardinal findings, oops, keep sliding. So with those cardinal findings, you're going to have contralateral hemiparesis of the upper extremity and the face more so than the lower extremity. Know that when I'm saying more so, that the lower extremity still might have some effect, but it's primarily going to be through the face, where you're going to see that facial drooping and upper extremity issues. And the patient more than likely is going to develop some spasticity and have what I call a synergist, or a synergistic pattern. You're going to see a contralateral sensory loss, probably still primarily along the face and the upper extremity, and to the lower extremities only to a lesser degree. If that MCA infarct or stroke is on the dominant hemisphere, which is usually the left hemisphere, you're going to see an issue with communication. They're going to have one of the aphasias, if not both of them. If they have both of the aphasias, it's a global aphasia. If it is Broca's aphasia, then it's going to be with motor speech, that's in the frontal lobe. So we can call that non-fluent aphasia or expressive aphasia. And I just make a joke to remember it and say, with motor speech issues, with Broca's aphasia, the person will not be able to express themselves. So it's expressive aphasia. Now with Wernicke's, they cannot comprehend, they cannot receive information and have it make sense. So since they can't receive the information and have it make sense, I call that a receptive aphasia. It's an receptive aphasia. That's your warning keys. This person normally has, they don't even know they have the problem, you guys. And normally for them, they're talking nonsensical. So if you remember when she called her coworker, she said he sounded kind of like Scooby Doo. And when she spoke, she thought she was speaking, but she sounded awful also. She wasn't able to receive information. Um, You'll also, because it's in that superior 1/3 of the temporal lobe, you just might have some issues with vision. So you might have a homogeneous hemianopsia where you cannot see one side of the visual field, either left or right. You're going to have issues with sensory discrimination, and you might have neglect. Now, neglect is normally going to happen if it is the right MCA. And I put that here for you, particularly with a right-sided lesion. So this is an important slide. Make sure you highlight it. Other things that you might see, and now this is more along that non-dominant or that right side, going along with that neglect. You're going to have that anosognosia where they really don't understand that they have an impairment. You might have apraxia where they just don't have any type of motor planning. They're going to have those perceptual deficits like neglect, much like I talked about in module 2, and then spatial disorganization. So they don't know left from right, maybe. They don't understand that they're hemiparetic on their left side. You hold up a hand and you hold up their hand and they're like, oh, that's your hand. Those are the types of perceptual issues that you're going to see with a right middle cerebral artery syndrome. Okay, so for some reason my slide is not showing, but it's supposed to show the PCA, and I don't know where it is. Let's move on to the findings, and if I find that picture after the next break, I'll come back to it, or I'll make sure that it's put on your post-sync slides, okay? With your PCA, let's just go back here. I'll go here. With your PCA, that's here in yellow, okay? This is your posterior cerebral artery along the medial and inferior aspect of the brain. And then here is it posterior wise along that occipital lobe and then underneath. So the posterior cerebral artery basically is going to supply that primary visual cortex and its secondary visual cortex, the occipital lobe, and it's going to also supply the inferior 1/3 or 2/3 of the temporal lobe. And you can see that from that medial aspect. So that's the PCA from that perspective. If you're looking at the PCA from the circle of Willis, here's your PCA right here. Okay, so I'm just missing the picture that I have to put back in, but I just couldn't, my brain would not allow me to continue to explain PCA deficits if you can't see them. Okay, so when we're talking about PCA syndrome or posterior cerebral artery syndrome, it's going to affect because it's along or it supplies the posterior lobe or the occipital lobe of the brain. You're going to have more visual disturbances, more visual issues. It also supplies the hippocampus, so you might have an issue with memory loss. So you're going to have things like contralateral homogeneous hemianopsia. Remember, I say that a lot, and it's going to supply 1/2 of the visual field, or quadrantanopsia, which is where there's probably an issue getting vascular or blood supply to optic radiations. Okay, the optic radiations emerge from I'm gonna just throw these words out, okay? We have our cranial nerve number 2, right? Our optic nerve. If you remember from last week's lecture, I brought up the picture and talked about those visual deficits that you could see of the visual field. But I showed you what the optic nerve looks like as it comes out of the retina, and then the optic chiasm and how the optic chiasm crosses over left and right. And then you have where it communicates with the thalamus via what we call the lateral geniculate body or nucleus. And no, you don't have to remember that pathway. And then it has those striations that come out and go to the primary visual cortex. So when you have issue with lack of blood supply to those striations that go directly or indirectly to that primary visual cortex, you can have quadrantenopsia. You can have cortical blindness. Cortical blindness is where you can totally not see out of one eye, left or right, or it's just the vision is really, really blurry and you can only see shapes. You can have visual agnosia, meaning you have no idea what you're looking at. You can see something, but you don't know what it is. It looks red. So let's say it's red and it's a circle. It could be a ball or it could be an apple, but you don't know. Okay. Um, Prospo agnosia, no facial recognition, so remember there are those things with vision that are going to be primarily impacted and object recognition when it's the posterior cerebral artery. Are we cool there? So now if you had to recap, if I were you and I'm sitting there trying to remember most important components of each of those that I would have to remember, and I'm talking about the syndromes, I would think of the homunculus. And I would think if this, okay, if it's the ACA, it's going to be primary, the lower extremities and the genitals. If it's the MCA or the middle cerebral artery, it's going to be upper extremity and face, motor and sensory, you guys, for both of those. And then if it's the PCA or the posterior cerebral artery, then I know there's going to be some type of issue with vision, some type of issue with recognition of objects in your environment. Those are your anaxagnosias or agnosias. Okay. So here's a knowledge check question. When looking at the brain from a lateral view, what cerebral vasculature do you expect to primarily see from that lateral view?
Posterior.
Posterior. So I got a posterior for one. Let's go to a lateral view. If this is your lateral view, which one do you see the most? Do you see green? Do you see yellow or do you see blue?
Green. So the middle.
This is the inside. This is a medial view. This is a lateral view down here. Here's the superior 1/3. Here is your lateral view here. And then underneath, that's underneath. This is the inferior view. You see more of it here. That's the occipital lobe. And then the 2/3 of the temporal lobe here. So from my vantage point, I don't know about you guys, I think I see more blue. Do you see more blue or do you think you see more green from a lateral aspect? Because your response this is the MCA. So from that lateral view, you'll get to see a lot of the MCA and its vasculature. However, from a medial view, if I cloned that question and I changed the answers and the stem of the question, I could say, okay, from a medial view of the right hemisphere, which vessel do you see? Medial superior view. I could say maybe I could put frontal lobe and parietal lobe in there. I could put anything in there that should trigger you guys in that stem to go to my correct answer of an ACA. Okay, where was I? Okay. So the correct response is an MCA, okay? Is that MCA view for you? Okay. So as far as vascular application, with the ACA, just as a recap, it's primarily the lower extremities and the urogenital region. With the MCA, it's going to be primarily the face and the upper extremity and the basal ganglia. And as far as the PCA, memory because of the hippocampus, visual integration, and oculomotor nerve impairment, and that primary visual cortex. So that's your vascular application on how you can study for these things and categorize your information. And this is just for study purposes. Okay, so now what I want to do is we know now that there is something that has happened with the person. And this is a hemiparetic gait, you guys.
I mean, that's when you're live with it.
They're just having their own side conversation in the back.
Eyes too, right? Because your eyes, yeah, not all people though.
His eyes, he was losing so much weight, and I kept telling him to go to doctors. Like he didn't have health insurance, so he never was trying to go to the doctors.
So tell me what you see. Tell me what you see with that hemiparetic gait. So let's break it down like this. So my first question is this. What side do you see most of the impairments? Left side or right side?
Right.
Right side. That's the side that you see the impairment on. So if you had to take a stab or a guess at what side of the brain had the stroke, what side of the brain had the stroke when you see right-sided impairments?
Left.
Left. And you can't see her anteriorly, but I bet you any amount of money that that lady's arm is kind of curled up like this. That's that spastic hemiparesis. So there was only one artery where I talked about something spastic and hemiparetic, and that was the MCA. So if I saw this person walking, I can't do any ahas. I haven't really seen any imaging, but if I took a neurologic educated guess, I would say that it was probably that left MCA that had issues. So, what else do you see with her gait? What are some other things that you see now? Let's talk about the lower extremities. What do you see with her lowers?
She's doing a step 2.
No?
What do you see?
Again.
She's doing a step 2.
She's doing a step 2 gait. What else? Let's see.
I mean, that's when you're live with it.
What does she have on her lower leg?
Orthotic.
She has an AFO on. And why do patients wear AFOs?
Stability.
They can be there for stability. I can take that answer. Any other guesses on why someone wears one of those? Think of what you learned in kines. You guys have had kines. You guys have went over abnormal or atypical gait, right? And you talked about maybe slap foot or drop foot, right? Why would someone have where's the weakness in someone that has slap foot or drop foot? Where is their weakness? Is it in the plantar flexors or is it in the dorsiflexors or the everters?
Dorsey.
More in the dorsiflexors. So oftentimes you'll have someone where they'll develop spasticity in the upper extremities, and sometimes they just have a lot of hemiparesis or even spasticity in the lower extremities. But they definitely have a huge issue with active dorsiflexion. And so what you'll do is you'll place them in an AFO, or what we call it's an ankle foot orthosis, in order to put their ankle and foot mechanism in a neutral position so their foot can actually clear the floor. So that's what you see her walking with.
His eyes too, right? Because your eyes.
What type of assistive device is that?
A hemi walker.
That is a hemi walker. And it should be in the hand or arm or on the side opposite, right? Opposite the impairment.
All people though.
His eyes so much weight, and I kept telling him to go to doctors. Like he didn't have health insurance, so he never was trying.
What does the patient need on them, though, that they don't have on them? That could be a potential lawsuit if they fall.
A gate belt.
Absolutely. That's what I hate about YouTube videos. Oftentimes they don't use the gait belt, but as an educator, I always tell my students, make sure that you are always wearing a gait belt. Gait belt, gait belt, gait belt for safety. Because as soon as you think that you're safe with your patient is probably the day that something happens and they just have a bad day. I do like the fact that she is guarding the patient on the hemiparetic side, which is where you should be when you're guarding your patient. I also enjoy the fact that the therapist isn't saying a word. She's not giving any type of feedback at all, which she might be fading her feedback away. So remember, we talked about that last week about fading of feedback when we talked about motor learning and motor learning strategies. Okay. So if we are correct, and this person does have an issue with the left MCA, and the left MCA suffered the stroke, what other issues would we expect to see with this person according to the syndrome for MCA?
Motor and speech impairment?
Motor speech impairments, perfect. So that is a nice segue into some of the left-sided structures that could be impaired. And I'm not gonna, I feel like I keep talking about this in every lecture, so I'm gonna stop beating that dead horse. I just have this here for you for study purposes. So remember that that motor speech area could be impacted as well as the language comprehension. And then I listed for you the other names for those. So you have your expressive aphasia, and that's Broca's aphasia. And then you have receptive aphasia or fluent aphasia. And then I know I talked about this also, but I like to hammer this home because oftentimes we're finding, even at BG with the MPT of our students, they talk a lot about the non-dominant side of the brain and its impact. So still just make sure for study purposes that you are studying these areas. So that right posterior parietal lobe is going to be an issue in regards to spatial issues. This right here is showing the inferior frontal gyrus, where that's opposite of Broca's area. So on the dominant side of the body, this is, or dominant side of the brain, this is Broca's. On the non-dominant side, we just call it the right inferior frontal gyrus. So with this person, since it's mirroring motor speech, but now we're not talking about motor speech, but we're talking about our nonverbals, how we communicate nonverbally. So if you're trying to throw the stink eye at somebody, if this area is injured, you will not be able to do that. You won't be able to do that. If you just try to keep like just a non-expressive face, that's usually what that person will attempt to do. You also have along the non-dominant side, the right temporal parietal lobe junction, which is the same area as Wernicke's area on the left side. So in that side, remember Wernicke's is for comprehension. So if it's damaged to Wernicke's on the opposite side or the non-dominant side, we just call it the right temporal parietal lobe junction. And if there's an issue in that particular area, let me get my pointer right in here, if there's an issue in that area, then that person can't read a room. That person can't understand that you're angry. The person can't understand that you're frustrated. They can't understand that you're happy. So they have a hard time or difficult time understanding nonverbal communication. So then that leads to my flat affect slide. It's not resting face, it's just a flat affect. And usually you will see this particular expression on someone that's had that right MCA stroke. And this is just a study picture. And then I already talked about neglect, but I just wanted to tie it all together now. So remember that on that right side, if the parietal lobe, especially the posterior aspect of the parietal lobe is impacted, remember that they have that left-sided neglect. Sometimes they're not even aware that they have a left side. And so the biggest issue for us evaluating clinicians, and then for you guys, because you carry on my plan of care, you have to make sure that you understand whether or not that person has neglect or whether or not it's a visual field deficit. Because if it's a visual field deficit, then you can really work with your patient. You just have to use a lot of verbal cues and tell them to look and scan their area and they're aware of their issue. However, with neglect, it's a lot more work for you because it's a lot of tactile cues, it's a lot of verbal cues, it's a lot of talking to get them to recognize and acknowledge their body part or their hemi body side and even the that side of their environment. So with laterality, I have it categorized for you for study purposes. You have, if you have that left hemispheric stroke, then the deficit or the impairment is on the right side. So these are some of the things that you're going to see. You're going to see right-sided hemiplegia or hemipresis. You're going to see right-sided sensory loss, same as the syndromes. You're going to see on that left side language and speech issues. And then remember all of those executive functioning components that happen or exist within the frontal lobe on the left side of the brain. So problem solving issues, difficulty initiating tasks, because we're talking about the primary motor cortex also, right? um they're going to have memory impairments or issues. They're going to have apraxia, not being able to come up with a motor plan or a motor scheme. They won't be able to calculate. They won't be able to categorize. Their executive functioning is going to be compromised in some form or fashion. And then if you have the right side with left-sided deficits, these are some of the things that you see. So remember, I talked about for the syndromes, that there's always something unique about that particular syndrome that's not in any of the other ones. And that's the same thing with neurologic pathologies. There's always something that is unique. So now with a right hemispheric stroke, you're going to have left-sided hemiplegia and sensory loss. You're going to have, especially if it's an issue within the parietal lobe, you're going to have an issue with some type of maybe spatial or visual neglect. You still have an emotional issue with a decreased perception of emotion, poor expression of negative emotion. Now, this person is the one that's going to be the one that cusses you out or gets angry with you. They're totally uninhibited. And this is going to be your impulsive patient also. So as you can see over here, as far as behavior, poor judgment, unable to self-correct, poor decision making and insight. They are a risk factor. The left-sided ones, they're a little bit more cautious because they're afraid, they're aware, and they're afraid of falling and things like that. As far as intellect and thinking with a right-sided stroke, they can be kind of rigid and inflexible. They're going to tell you what they don't want to do. Difficulty synthesizing, difficulty with problem solving. Okay. How you guys doing? I know I'm throwing a lot at you, but honestly, this is all the information that you're going to need hopefully in regards to your studying. I just want to end out with a handful of lecture notes on how we manage. Are we still good on time? Yeah, we're still good on time. Okay. So I want to quickly go over how you're going to manage your patient stroke. This is because I think the lecture was so long that I gave for that. I just wanted to put some highlights up. So with medical management, we need to stabilize our patient, right? So the biggest thing is the body systems are going to be impaired in some form or fashion. So cardiovascular rise, you're going to see a decrease or reduced cardiac output. You're going to see a decreased heart rate max. All of those physiologic things regarding cardiopulm are going to be decreased. Okay, so this should have came up in physiology with your AMP. This is the physiology component. What you're going to notice is all of that functioning is going to decrease. Look, with pulmonary, it has decreased lung volume, decreased pulmonary perfusion and oxygenation is going to take place. Decreased vital capacity and chest excursion will take place. So there's going to be some type of respiratory compromise. And then you have to make sure that you're managing their clot activity, especially if it was an ischemic stroke. Oftentimes, until they're anticoagulated, they will be on bed rest, and that's usually 24 hours until that's in their system. And then other body systems that'll be affected are going to be bowel and bladder. Other issues that they might have are increased seizure activity, Osteoporosis is basically for that very severe bedbound person that's had a stroke. They end up getting fragility fractures when they move, especially if it's really severe and they've been bedbound for a long time. I'm sorry if that's hard to read. I hope it's showing up larger on your screen. But as far as pharmacologic management, because of the seizure, anticonvulsants, they're trying to control your cholesterol, so anti-cholesterol agents. They're trying to control your blood pressure and the clotting activity. So you have thrombolytics that you're giving, anticoagulants that you're given, antihypertensives that you're given. So pharmacologic wise, you have to make sure that you're understanding the medication your patient's getting. From a skeletal perspective or musculoskeletal perspective, sensory loss, right? Motor issues with reflexes. They might be more hyper reflexive. They might be more spastic in regards to their tone, right? As far as strength, they're going to be weak and they might have some type of atypical or abnormal gait. Their balance. Remember the man in the Be Fast video? He kind of went towards the hemiparetic side. So they're going to have an issue with their balance, their posture. They like to sit on the dominant or the strong side. They're afraid to weight bear on their hemiparetic side because they know they're going to fall. So their balance is oftentimes asymmetric in sitting and with standing. And then just they're predisposed to lack of flexibility, tone, I mean not tone, but they could develop contractures and things like that. So from a physical therapy standpoint, those are a lot of the things that I'm going to look at as the clinician and what I'm going to treat. And then make sure you understand that from our previous lectures that they can also have cognitive issues, perceptual issues, and issues with communication, right? But now when I say that, in your mind you should think, oh, brokers, wearing the keys, oh, neglect. Things like that is what you should start thinking of when people say things like cognitive issues, communication issues, perceptual issues with someone that's had a stroke. So, from a therapeutic vantage point, we have a lot to work on. You guys, as the PTA, you're going to basically follow a plan of care, but that doesn't mean that you shouldn't know how to assess and interpret, right? I think that would be an insult of your intelligence. So, how are you going to get your patient to actively move and facilitate? How are you going to help improve their strength? How are you going to drive their neuroplasticity? How are you going to improve their atypical gait? What are you going to do to work on their posture and their balance? What are you going to do to improve their functional mobility, maybe from sit to stand, from a max assist to a mod assist to a min assist to contact guard assist to modified independent or even dependent? And what type of patient education are you going to have regarding your patient's safety? So all of those things come into play. Now, the next two slides, I think it's kind of, I know that you guys go over this or you were supposed to have gone over this in your lab. And I'm going to make sure that I re-emphasize this. When you have someone with a stroke or even with a brain injury or a TBI, you will find that they have spastic patterns, synergistic ones. And you can have in the upper extremity a flexor synergistic pattern or an extensor synergistic pattern. You guys are responsible for knowing the patterns. These are different from PNF. Okay. They're different from PNF. So this first one, that flexor synergistic pattern, that's when you see that patient doing this when they try to move. Okay. You can go through, everybody take their hands, do that. Go through that on your own. Feel the position your upper extremity is in, that elevation and retraction of the scapula, right? Your shoulder, where it says abduction, external rotation, because your arm is not out like a chicken wing, okay? So you have your abduction there. You have your elbow, that's in flexion. Your forearm is in a supinated position, and your wrist and your fingers are flexed, right? In direct contrast, you have the extensor synergistic pattern. Put your arm in that position, protract your scapula and bring it forward. Adduct your shoulder close to your body and internally rotate it. Extend your elbow and pronate your forearm and still flex your wrist and make a fist. That's what that extensor synergy looks like. That's that patient that has their arm kind of dragged down to their side. So make sure you go through and feel what those synergistic patterns feel like. That way, if you have a question, you're able to recognize the pattern, right? And the same thing occurs with the lower extremity as well. So here's for you. Know these, know these, know these. Okay? Know all of those terms. They are inside of your lectures, your video lectures, or if you want a shortcut, go to your Big Red, go to your O'Sullivan, and all of those terms should be in that glossary for you. Okay. Know these terms. These terms have come up in previous video lectures. Bradykinesia, chorioaptosis, hemiballismus, apraxia, dysmetria, dysdiadokinesia. That's all in the previous videos on your LMS, and they are also in your Big Red. And they're also, I do believe that all of these are talked about in those worksheets that you guys have from Karen. There's one worksheet that goes through every last one of those terms. And that's all I have for you. I think it's about time because I can see that y'all hitting y'all wall because I am too. I am done. You are done. Okay.
Yeah. Yeah.
Do you guys have any questions for me?
I just want to make sure.
Go ask her.
So whenever we go to look at the after class post sync session for
Yeah.
week 2, is that video supposed to be up?
Okay. So are you talking about what's in the sync materials? So on your LMS, when I have the sync materials, you'll see sometimes you might see pre-sync slides. I really didn't have any pre-sync slides this week, so that's why I didn't put any up. But definitely I'm going to put up post-sync slides. When I put up the post-sync slides, it's going to be everything that we had here today, but it's not in a PowerPoint. It's just in a PDF. And so it just scrolls through what the slides say. But you should have now on your LMS in the modules section, I put sync sessions for you, and you have the links to the sync sessions in there. So after this is done and Miss Denise presses stop recording, I'm going to have her send me that link, and I'm going to put that link inside, and it's going to say sync session number 3. So now you have me talking and you have this entire lecture or you have this entire sync session to go off of. Does that
Right,
help?
I understand that, but I'm asking about for module 2 sync session that is posted on here. For the post sync session, whenever I click on it, it is only showing the PDF to where you can scroll through it. I'm not able to access the videos of you giving more description to the PowerPoint.
You're not able to get this video, is what you're saying?
I'm not able to access any of them. I can't, there's not a video for week 1 or week 2.
Okay, because I just did it today, because I just found out today. Nobody ever told me. So video, I don't think we press record for one, but if you go to the LMS, go to where the modules are, scroll all the way down because I just added it this morning before the session. It should say sync session number 2. Can you see that?
Yes, ma'am, I'm on it right now.
Okay, is it not coming up?
No, ma'am. It's just, this is post sync session and it's just the PowerPoint. So whenever I go out of it and I press close, it's only giving me links to the PDFs for the first one and the second, for
Okay,
pre and post.
hold on, cancel. And then let me do this. And here. Okay. So I'm going to go here and I'm going to go here. Now, My screen looks a lot more confusing from you guys', so just pay no never mind to how much stuff you see, okay? So you see my screen. This is my module section, and I'm going to go all the way down. Remember, I said pay no attention to that. And see where it says you have that part where it says sync session recordings, right? So you're saying you're going into there because I'm going to go into, and then where it says this right here, does it give you that? And does it allow you to say allow? And then from there, it should open this up. And this is what you're not getting. Maybe I might just have to email it to you then if you're not getting this, because this right here goes through everything. With your block practice, they need equal rest time.
Yeah.
And then I'm going to go ahead and try to open. Okay, so you're not getting that.
I'm trying to find this. So whenever you scroll all the way down to the bottom and there's that little slot, I'm trying to find it currently and I'm not.
Hey, Tawana.
Oh, you know what? I know why. It is all my fault. I know why you don't have it. Operator error. I bet you I can make it magically disappear. I can make it magically appear for you, my friend. I can make it appear. I can make it appear for you. I'm going to press this green tab. I bet you can see it now. Can you see it now?
Let me refresh. Yes.
I am so sorry. My apologies. Now it shows up. Denise, I can't remember if I pressed record for the first session or if you pressed record for the first session because I can't remember. It was probably should have been me. So
Yeah, this is the first time I've ever pressed record.
okay, so I'll have to go back and maybe contact IT because I thought that I pressed record, but it hasn't come through for me yet. So if I can find that one for sync 1, then we'll have that. All right. And so, like I said, afterwards, I'll get on here and then hopefully Denise will get me the link and I'll put that up here for us. I got to put up here and find it.
I have a question does anyone have any other questions for her regarding anything that was covered?
At the moment.
At the moment, okay. Tawana,
Yes.
was this format a little better? Like, were you able to see all the students and all that, or?
Yeah. Yeah. I don't know if it's better for you guys, but it was better for me. So it just depends on how you guys want to keep it.
Okay, so you can see the tile of the room and all that, right?
Mhm.
Even when you share stuff? Okay.
Yeah.
Just want to make sure.
Mhm.
Okay.
Okay,
I have
gang.
never down yet because this isn't through my email, so I can't save it.
That's all I
Tawana,
have for you.
Okay, Tawana, I have to get our IT person here, so I'm not shutting it down, so I can copy the link.
Okay. So if you all you have to do is press stop recording and then give
But
it a
it
little
didn't come
bit.
through my email. It's not
No, no, no,
coming
no,
through my
no.
email.
It's going to come through your Teams.
It's not coming through me, though.
Oh, is it going well, it depends on who set the point, who set this up.
But I don't want to lose it.
Well, I don't
It
think it'll pop up and stop recording.
it won't.
Right?
It depends on who set the class up. See, I didn't set this up. So whoever set the class up is going to appear in your Teams underneath where your chat is.
Right, and it didn't come through me, it came through the school. So I didn't set it up through my email address. That's what I'm trying to say.
Okay.
If it was coming through my email address, I would be able to save it.
Well, I'll
But
just
I
wait.
can't.
I'll
Yeah.
just wait.
So
I'll just wait.
I just texted our IT person. But I think you will be okay if you exit, I mean, because it's from my end here.
Mhm.
I don't want to take any more of your time if you.
Okay, you guys, reach out to me with emails if you have any questions, okay? I'm at my desk all day. Okay, take care.
Thank you. I just don't wanna exit out and then.
Module on Canvas.
Did you refresh your computer? Refresh your screen and then.
Hold on.
She just moved it back up to the top, so I don't know.
I'm on one of the PowerPoint.
Uh,
So go back here and on the topics. And then underneath the videos will be the PDFs.
so why did she so loud like that? Which one are you on?
I have no idea. Topic 3, medical and therapeutic management of stroke. That would have been a great question for.
Put this on myself. That's why I don't put my screen.
I don't wanna lose it.
Like have.
Just let it continue, it's not gonna do that. Or stop recording, do that.